Welcome. Thank you all for joining Alterra Medicare Medicaid Services for States webinar, How 3 States Are Improving Programs for Dually Eligible Individuals. We're called AMS for short. AMS is a nonprofit organization created to support and partner with states to improve and advance programs tailored to individuals eligible for both Medicare and Medicaid. Over the past couple of years, we've been working with a number of states and love to share experiences across states, and that's why we are here today. We'd love to share the experiences with Maine, Michigan, and Tennessee. We are also very excited to have a leader in this space, Melanie Bella, kick off today's webinar. And then we will hear from the 3 states who will share their experiences, challenges, and successes building better programs for dually eligible individuals. As you all know, they're a diverse population, but all are low income, over the age of 65, and or living with a disability. And most must navigate to complicated programs that were not designed to work together. States are at different places with internal capacity and expertise around the Medicare program and coordinating the 2 programs. But we're here to share that there are steps that each state can take to improve the lives, healthcare, and outcomes of these individuals. I would like to briefly introduce our panelists. I'm not going to go over their bios, but we have Olivia Alford from Maine to talk about the program enhancements that they've already put in place and their path going forward. Lolitha Gilbert from Tennessee, their expansion of eligibility and enrollment in their fully integrated dual eligible special needs plans. And Matt Seeger, going over Michigan's transition from a dual demonstration to a permanent statewide program through the use of a competitive capitated D-SNP procurement. With that, I am going to introduce our opening speaker, who needs no introduction, but Melanie Bella, Executive Advisor, Cressy & Company, and the former, and may I say first, pioneer director of the Center for Medicare and Medicaid, Medicare-Medicaid Coordination Office to talk about the current landscape, the demographics, and why this work is so important. Thank you, Melanie.
Thank you, Sarah. I appreciate you including me. I tried to create sort of this aura behind me since this is such an important topic that hopefully everyone gets as excited about as I do. I'm just going to do a little bit of stage setting on who the duals are and, like Sarah said, why this is important. I'm going to be very quick because it's much more important for you to hear from the states. So most of you on this call already know that we have, at any given time, a little more than 13 million duals. The majority of them are full benefit duals, so about 73% are full benefit duals and about 27% are partial benefit. 65% of the duals are over 65, but it's really important not to forget that we do have 35% of the dual eligible population is under 65, which means they have a very different set of needs, and the solutions that we develop and the engagement strategies are different. Annual spending on the population is now close to $500 billion. So that is, yes, $500 billion and growing. It is an issue that has bipartisan interest, I think in part because of the spending, and is an area where we have a huge opportunity to make dents in that spending. For Medicare specifically, duals represent 35% of the spending, even though they only represent 19% of enrollees. And on the Medicaid side, it's about 27% of spending for 13% of enrollees. So again, just to repeat, 13 million people costing us $500 billion a year. And arguably, I don't think any of them really feel like they're getting the value or the ease of experience for that sort of spending. The average per capita cost for a full benefit dual is $44,000 a year. So obviously that swings up and that swings down, but clearly, this is a complex population with lots of opportunities to do better. Long-term services and supports use drives 75% of the total Medicaid spending for duals. So again, think of that as an area of opportunity where we can work with our state partners and support them to really inject quality into the LTSS system. Given the complexity and the costs that I just mentioned, it should be no surprise that duals are medically, behaviorally, functionally, and socially more complex compared to regular Medicare-only beneficiaries or Medicaid-only beneficiaries. They have higher rates of chronic condition, higher rates of depression and serious mental illness. More duals need help with activities of daily living and more activities of daily living, and they have higher self-reported poor health status. So again, those are, it can be pretty stark when you look at all of those statistics, but instead thinking of that as an opportunity is really kind of the promise of what we have when we think about integrating to the two public programs to serve this population. So in the state landscape, we have seen growth in integrated products. The growth is steadily increasing. We're still at about 22% though, as of 2023, meaning the majority of duals do not receive their Medicare and Medicaid services through the same organization. So that number, like I said, is ticking up. But if you're in that 78% that don't have that luxury, we need to do better. There is a wide mix of both fee-for-service and managed care delivery system arrangements. On the Medicare side, duals can choose Original Medicare, which is fee-for-service, or Medicare Advantage. Within fee-for-service, a dual could be in an ACO or another CMMI initiative. Within Medicare Advantage, there's any number of acronyms that duals could be in: DSNPs, DSNPs, iSNPs, lookalikes, regular Medicare Advantage. So it gets to be really confusing, but I think if we think about how do we get people to get as many services as possible from the same entity that's held accountable for their care. Importantly and interestingly, DSNP enrollment growth has outpaced overall Medicare Advantage growth. There are about 6 million duals in DSNPs right now, and there's a lot of consolidation. So in last year, 52% of DSNP enrollment was in just 2 of the large national plans. So something for states to think about as they think about how to put together their Medicaid strategies with the Medicare footprint. On the Medicaid delivery system side, it varies by state. Some states have managed care for their LTSS program. Some capitate Medicare cost sharing. Some employ some managed care, but maybe carve out behavioral health. And in some states, duals are in straight fee-for-service for all of their Medicaid services. And states face critical capacity constraints that meaningfully impact their ability to prioritize integrated care for their dually eligible individuals. You'll hear today how these 3 states got started and what additional things would support their continued work in this area. Another material constraint is the lack of shared savings between Medicaid and Medicare, which really hinders the state's incentives to invest in integrated care. There were 2 mechanisms for sharing savings. One was a managed fee-for-service model in Washington state, and the other were some financial alignment demonstrations in something called the Medicare Medicaid plans. Both of those are being phased out though, and there's nothing similar in place for fee-for-service states or those who are using DSNPs as their integration platform. Again, an opportunity for us to think about how do we align those incentives. So the key objectives, I mean, we can make them complicated and we can use a lot of acronyms, but at the end of the day, I think the key objective, number 1, is make it easier on everyone, especially dually eligible individuals and their caregivers and their providers, and ensure they are getting high quality care that for many is just not the norm today. Secondly is ensuring dually eligible individuals get the benefits and services to which they are entitled and which they need in order to live independently in the community. Also important is holding an entity accountable from a clinical, financial, and quality perspective. There's too much sort of cost shifting that happens, which leads to the last objective, which is aligning incentives and ensuring the states and the federal government are equally motivated to do this work. So in closing, I'll just say it's really exciting that there's so much interest in this topic again, and it's bipartisan interest. At a recent panel at the Medicaid Directors Conference, one state Medicaid director reminded the audience that these are our members too, commenting on how important it is for states to drive improved quality and not be an afterthought that takes a backseat to Medicare. We can support states through data and analytics support, capacity building, and shared savings mechanisms. And I am really excited to hear from these 3 states today on the tools, pathways, and strategies they are using to improve care for their dually eligible beneficiaries, and words of wisdom to the rest of us about how we can support their efforts and those of their peers. So with that, Sarah, thank you again, and I'm really excited to hear from the states.
Thank you, Melanie. And what you just said resounds with all of us, and that's why we're here and why AMS exists and why we really want to see and hear from the states that what they need, how they've succeeded, what challenges they have, and supports that they need. So I'm going to turn it over to our panelists who you all want to hear from. And I'm going to start with the first question, which is, given your state's resources, what were the primary goals your state set out to achieve in designing or redesigning programs for dually eligible individuals? And how did you get started on that work? And I'm gonna ask that Olivia start us off.
Awesome. Thank you so much. It's really wonderful to be here. I get so excited when I hear people like Sarah and Melanie talk, because I think the goals we're trying to achieve in Maine have been stated already. And we'll talk about how Maine is one of those states that has no managed care in our Medicaid program. And so some of those challenges about where is the incentive, where are the resources, how do we do alignment, is true for Maine when we'll talk through today's questions. But what our goals are shared with, I think, what you've heard already. We want there to be an improved experience of care and health outcomes for dual eligibles. For Maine and our unique environment, in some ways unique, we really see the need to create a lot more stability in the provider systems and the community systems that support dual eligible members in their communities. We are have a goal, and our first steps have really been related to the goal of leveraging resources, whether that means exploring ways to share in some savings, or to just leverage what resources come through things like dual special needs plans contracts, so that we can build additional capacity and stability within our Maine systems. So we've entered into this work with those initial goals. What have we done to get started? We are one of the states that faces some significant capacity challenges when it comes to doing this work. So we really had to start at really 4 basic things. Under our current administration, this has become much more of a focus. We've needed to build knowledge among state staff related to Medicare and dual eligible. Not that there weren't people doing certain work, but it wasn't an area that had been focused on as it really needs to be, as a special population that needs different and unique interventions because they have a different and unique experience. And then not just one population, but multiple populations within that. We've taken advantage of national learning resources like the Medicare Academy from the Centers for Healthcare Strategies, which I highly recommend. I think it's still ongoing, the Medicare Academy. Integrated Care Resource Center, all those sources that are available to states, we've really tried to leverage those. We started convening an internal department group, of an affinity group for Medicare and duals, to get everyone who was doing siloed work that did relate to dual eligibles and Medicare to come together quarterly and just talk. What do you do? What do you do? Because it wasn't, again, a topic that had been discussed about as an entity, more just that people saw it as part of their jobs without connecting it to the broader fact that this is a population of importance across all of these functions. We leveraged our 9817 home and community-based services spending to work with Altara Medicare Medicaid Solutions, which was very important for us, to really do a full-blown strengths, weaknesses, opportunities, threats analysis, and develop a roadmap for us, and really a really great job doing a data chart book so that Maine had better insight into even the population of duals within our state, which again, we just didn't have the capacity to do internally. And then the last thing I'll mention, you'll always hear what we started with is needing to have a champion in leadership to elevate this conversation. And so far, that has been a role that I have played. But as you build out your teams internally, you're trying to build the champions further in the organization. But certainly, with all the priorities and where Maine is coming from, you aren't able to add to the list without someone pushing forward this initiative. So we have a number of champions, but it's very important that we had that as one of our initial steps.
Thank you, Olivia. And this is the only time I'm going to interject because I was remiss. Please enter questions that you have in the Q&A function at the bottom. And we have reserved time at the end for you all to engage with the panelists. So thank you. And I hand it off to Matt.
Thank you. So, as far as Michigan's goals with standing up our highly integrated dual special needs program, which is going to go live about a year from today, January 1st, 2026, it was really to continue some of the work that has been happening for a long time in this state. So Michigan is one of those states that had a duals demonstration project. In Michigan, it's called My Health Link. It will have been going for a decade by the time it concludes and transitions over to our highly integrated dual special needs program, which we're calling My Coordinated Health. In Michigan, everything starts with my, MI. We are also a managed care state and have been a managed care state for a long time. So that creates a couple of opportunities for us. We have a really strong model already in My Health Link that we can build on. And we also have a very, very robust sort of mainstream Medicaid managed care program where we can take concepts and resources from that and kind of apply it to what we're trying to do with My Coordinated Health. So quality measurement concepts, some of the resources around concepts with coordinating with the various entities in the healthcare environment, particularly in Michigan, there's a little bit of extra work that goes into connecting with behavioral health services. Some sectors of behavioral health are carved out, as we say in Michigan, and not provided by the main Medicaid health plan. So there's an element of coordination there. Our goal is to continue on those successes and launch and make it better than ever next year when we go live. So we want strong LTSS, we want strong population health metrics appearing in our quality, and then of course racial equity is a huge focus in all the work that we do in Medicaid managed care here in this state. And that's something that we'll be looking at very closely too in terms of this program. So those are some of the key things we're trying to achieve.
Lolitha?
Thank you, Sarah. Good afternoon, everyone. So as far as Tennessee, I came on to Tennessee a couple of years ago. We were in a very unique position, previously having a subject matter expert running all of our DSNP work for the state, who made the decision to retire. And so the state then decided that we needed to have another individual that would be specifically dedicated to the DSNP work in the state. I fortunately was elected to move into that position. And so for the past 2 years, we've been learning as much as we possibly can to build up the DSNP work. So initially coming on, knowing that, Medicaid knowledge was readily available throughout the agency, but we really needed to ramp up the Medicare knowledge that was within our managed care LTSS division. So one of the initial things that we did was we conducted a review of all of our LTSS programs to determine the percentage of dual individuals that were enrolled in the program. And what we found was there was a really large percentage across the board in all of our programs, which then allowed us to connect with all of those program leads. And then we immediately had partners in the work, because it wasn't just them thinking about their individual programs, but then we had an opportunity to introduce DSNP and to conduct some specific trainings with those individuals initially. again, to expand and to build on the Medicare knowledge, because again, we had that Medicaid piece, not necessarily the Medicare. So we were fortunate enough to receive the assistance of AMS. So working with Sarah and the team, we've really been able to develop a lot of tools that we have utilized to conduct internal and external stakeholder trainings that have assisted us in expanding the knowledge across the board, our quality teams, our reporting teams in behavioral health, and a lot of, again, of our other LTSS programs, which then building that knowledge, again, we've been able to work together to expand the work and to really get things started. We also had the opportunity to take part in the Medicare Academy this past session, which was a great benefit to the state. And we've utilized that along with the TA assistants to develop communications plans and additional initiatives around some specific quality areas and multiple things to ensure that we can work with several divisions, again, internal and external, and move multiple projects along at the same time.
Thank you, Lolita. And I'm going to start with you again with some state-specific questions here. So we know that you're planning on opening up or just expanding eligibility for, I'm going to say not the acronym, but fully integrated dual eligible special needs plans, one of the most integrated aligned models other than the current dual demonstrations. How do you plan to communicate the value of enrolling in what they call the alphabet here, the acronym is FIDE SNPs, fully integrated plans, to members and ensuring the quality of the program?
So I think we have a lot of different things that we're currently working on to communicate that, right? Initially, we met with our plans to ensure that everyone was on board and knew exactly what the goals were, and you know, to make sure everyone was considered in the process. And as we move forward together. In the state of Tennessee, we went a step beyond the regulatory requirement for our initial FIDE program and had what we called a choices limiter. So only individuals who were eligible, you know, dual individuals eligible for the fully integrated option, they also had to be enrolled in our choices program to enroll in that FIDE. We have made the decision to remove that effective January 1st, 2026. And prior to that, as you stated, we've met with our quality team, we've met with our communications team, we've reached out to internal and external stakeholders like our SHIP division to ensure that they are aware of the benefits around individuals enrolling in that fully integrated option. I think as Melanie stated, and we see those expenses that are incurred by this population, it's very important for us to ensure that we are providing the most integrated option. And we're moving forward with a lot of the initiatives that came down in the final rule for 2024 to move the program forward, but to make sure that as we continue to work with this population, and we will move the fully, the full benefit dual eligibles into that fully integrated option, because we know that that is the best option from a fiscal standpoint, from coordination, and from the integration perspective. It's the best option for the members, and working with those stakeholders to communicate that, I think is what is assisting us and will assist us in moving members into that option quickly, and they will then begin to see the benefits of moving, if it's from no coordination or moving from a coordination only plan into that FIDE option.
So moving from, you know, expanding an established integrated program, want to move to asking Matt about Michigan's effort to, you know, turn from a demonstration to, you know, what were the key considerations for moving forward with a competitive procurement for your statewide permanent program, a capitated DSNP program. You can say a little bit about what that means. And, what is relevant to all states, sort of what they should consider when moving forward with implementing this type of program.
Yeah, thanks, Sarah. Great question. So certainly we did do a competitive procurement, and in fact that went through a couple of iterations, but the latest version of the award announcement came out a little bit earlier this week. So we're very excited about that. Yeah, in Michigan, the arm of state government that procures large contracts like these is fairly distinct from the like the Medicaid program area. So to a certain extent, the decision to put this through competitive procurement really just came down to them saying, hey, Medicaid, this is how you're going to have to do it. But those of us in the program area, definitely took this as an opportunity to really lay out what our priorities are for the program and, signal to people, to organizations that would be interested in being part of this, that here are some of the things that we're going to expect from you. Strong LTSS component, strong quality program, strong focus on population health and equity where there's inequities with various populations. So that's the beauty of a procurement, is you really get to identify those priorities. It was also an opportunity for us to bring in some players that we knew could bring something to the table that Michigan Medicaid really hadn't been working with closely before. So we do have coordination only DSNPs in Michigan. The level of Medicaid oversight over those is relatively minimal compared to CMS's role. But we know that those organizations potentially bring a lot of experience, and we wanted them to have an opportunity to throw their hats in the ring as well. What I would say to any state that's looking to launch a HIDE SNP or a FIDE SNP is treat it as an opportunity to put out hey, here's what we really want to see the quality of care look like and the model of care look like. And if you can bring this to the table, then please be our partner. And I do want to give a shout out to the AMS team here who helped us put together some of those procurement materials and really helped make sure that Michigan's vision shined through, so that bidders who were interested in participating with us knew that, hey, if you want to work with Michigan, these are the priority areas where you're going to have to devote a lot of resources.
Thank you, Matt. And turning from a state that, went through a competitive procurement, had Medicaid managed care and somewhat of an infrastructure for overseeing managed care, turned to Maine, a state, a state without Medicaid managed care. What are some of the things that you are doing currently? And what are you planning to do to improve, programs for dually eligible individuals and improve quality and cost efficiencies? Thanks. Olivia.
Yes, thank you. And I appreciate Sarah's language, because I think one of the things that I'm always going to say is that when you talk about states that don't have Medicaid managed care, it does not mean that they are fee-for-service states that only pay out on a fee-for-service basis. And so I'll talk a little bit later in my remarks about our alternative payment models, like our accountable care organizations and other value-based models that include duals. But first, really, what Maine does have, and is a national trend, I know, is that we have a whole bunch of DSNPs and a very significant growth in the shift towards Medicare Advantage and away from traditional Medicare in our state, in a highly saturated, I guess I would consider saturated, maybe not yet, but full market, I'll say, for how many plans are being offered within our small state. When we first started this work, there were more federal options on the table with the other models that Melanie discussed that are no longer an option for our states. And so where our focus has shifted is really just first to leveraging our coordination only DSNP product that we do and have a growing level of oversight and expectations put within those contracts with our DSNP partners. To give you a sense of it in Maine, most recently, it looks like almost 70% of the Medicare population is in a Medicare Advantage or DSNP level product, and that there are almost 40 plans. And I don't know what those numbers are in other states, but Maine is not a large state, so it's a lot of plans to choose from, and people are getting a lot of marketing put towards that. So when there's a D-SNP plan on the market, we want to make sure that there is value for people in that plan. And we've had a number of years of developing better relationships or relationships that didn't exist before directly with the health plan points of contact, having quarterly calls, improving our reporting structures, and adding elements of requirements to the contract that go above and beyond the standard template language that you'll see online. So some few quick examples of what we've done. We've required the D-SNP plans to coordinate with our service coordination agencies, which basically coordinate home supports for people, older adults with needs for activities of daily living within their home, requiring MOUs between the two entities so they can work collaboratively when they have shared members, and then sharing data so they can identify their shared members with one another, and facilitating just a relationship that didn't exist before between those two partners that are closely involved with the same member's care. We've leveraged the D-SNP contracts to have them help resource all of the nursing facilities that they contract with in the state to be connected to our health information exchange. That was related to the additional requirement around admission and discharge notifications that the state, with no managed care infrastructure, has no business in receiving. What we need is for the folks on the ground who are doing the work for these members to receive notifications, and the nursing facilities were able to be connected through the resources that the D-SNPs had to put forward, because we put that requirement on them for that federal requirement that came down to us. That's trickled down into some really meaningful conversations about how nursing facility transfers of care can be better within our state and for members. So again, aligning some incentives across other state efforts related to nursing facilities has been a nice thing that's happened stemming from this initial D-SNP coordination only requirement. And then we're really starting to focus on the value that's offered and then realized around supplemental benefits and value add benefits by digging a lot deeper into that to make sure, again, that the folks that are in Maine that are receiving the marketing materials and such buying these or signing up for these products are getting value out of what is being advertised. But just to turn quickly to the fact that we do have alternative payment models that include duals and very deliberately include duals in the methodology and the way that we account for their total cost of care. We are now in a better place and have been looking more into how dual data is different, what we receive as data and what the total cost of care looks like, and to a question we'll talk about in the chat later about where the cost drivers are for Medicaid. Those are all different for duals. And so we have been looking both at the cost and quality data, but also at what care delivery requirements or program requirements we can put into place in our performance-based models to add accountability for this population. So that's a growing area that we've been looking at, but it has been really helpful to have, again, this better cross-office awareness to this population so that when folks are writing policies and designing metrics, that they're thinking about this population specifically when they're doing that.
Thank you, Olivia. I'm going to go back to, and thank you all for all your perspectives and really coming from different, environments and landscapes. I want to turn to something a little bit that we've mentioned. You've mentioned data. And really we've been hearing that we know a lot of states are challenged with, what data is out there, what do we do with it? We don't want to just get data for data's sake. So how is your state managing data to inform program oversight and policies? Turn to Matt.
Yeah, so in the state of Michigan, it's all about the encounters, and we, which I'm sure most people are familiar, but that's basically the equivalent of a claim in the managed care world, where a service gets rendered, and then we have information about the cost of that service and who received it. That gets sent to a central data repository that we have here in Michigan that we call the data warehouse. And that really drives, those sorts of units of information really drive a lot of the work that we do. We set rates based on the encounters that we receive. And so that helps us kind of predict what costs will be for upcoming years. And then, of course, I've talked about quality a few times. Most quality measurement, not all, but most quality measurement can be done using those encounters to sort of see where services were rendered or not rendered as we're looking at population. So we have some very robust encounter quality initiatives that are statewide. It doesn't just apply to our current duals demonstration or our upcoming HIDE-SNP model, but it certainly does include that. There's always room for improvement. We always want our encounter quality to be better. We have encounter data validation reports that are done by a third-party vendor. You can find those publicly on our website. And if you look through those reports, you'll see that we have opportunities to do even better with strengthening that data. But that is certainly what will be driving My Coordinated Health as we look towards the future. And we have some new challenges in that space as well. So we were very fortunate with our duals demonstration, our MMP, which again has one more year to go, where specifically thinking about quality reporting, our CMS partners would actually collect the quality data, compile quality performance for the state of Michigan and give us the reports. We didn't have a whole lot of work to do other than sit back at the reports, and then we could chase after our plans and tell them to improve. And of course, we have a quality withhold and some other actual incentives around that. As we move to My Coordinated Health, CMS's role in that space will disappear, so we'll have to do our own quality measurement, which will, by necessity, probably need to include looking at Medicare encounters, which is complicated. It's, I think, relatively unusual for states to be looking at Medicare and Medicaid encounters together to get sort of an aggregate view of the beneficiary's experience in terms of what services they're receiving. We haven't needed to do that much up until now, but we are going to be all in with that with My Coordinated Health. Certainly there are some extra considerations when you're a state Medicaid agency looking at whether the quality of actually Medicare essentially claims data, again, encounters that's coming in, whether that's of high quality. So we're working on that now, but that's very much on our minds. I will say that if any of the guests on the line have a phenomenal system set up for kind of looking at your Medicare and Medicaid claims together, drop me a line. I'd love to hear all about it. But that's the big data consideration that we're thinking about right now.
Thank you, Matt. I turn it to Olivia.
Thanks. I'll be relatively brief on this one. I wish we had some of the things that Matt is talking about. I think that's again one of the deficits of coming into this without having us in any system within the state that would ingest encounter data. Not something we work with, but we went through the process with AIMS again for this strengths, weaknesses, opportunities, threats, SWOT analysis. And we came out fully agreeing that the data infrastructure really is the first thing that Maine needs to invest in further, along with engagement with community members, and providers. But what we want to do is really think about all the data sources that are available to us, and then realistically within our resources, and we'd welcome additional resources, try to build out the platform or the warehouse that will enable us to better monitor this population. What we have now is really based on our Medicaid data alone. Other elements of data oversight that are being used right now to inform the program are our total cost of care analytics on the accountable care side of the house, and then also the reports that we receive from our DSNPs, which I'm sure all states who have any kind of managed care contract or even a DSNP SMAC, state Medicaid contract, you're asking for reports from these folks regularly, and you're doing your best to actually review the data that you've asked for and use it in decision making, which let alone was a process for us to really have the capacity to not just ask for the report, but then to read the report and use the data in a way that was meaningful. So we've really tried to get to a good place, and I think we're getting there with what those reports do and do not mean. The learning curve on that front, sometimes what you get is not what you thought, and really diving into the value of those reports and how they can be used within the team. One of the uses that's I think has been most valuable is looking at just even the enrollment in the DSNP products, which DSNP products, and then I think Lalitha, you mentioned your team did this as well, what programs or waivers or other initiatives are those members a part of, so you can start to build the conversation and the around what are the service needs, where are the opportunities. And so that's an area that was really valuable to just even use enrollment data for, to match these members with the Medicaid language inside of the house.
Thank you, Olivia. And then I turn it to Lolita.
So I think, you know, when you're considering data, it's so broad, right? So, you know, in talking about this work, there's so many different areas that's touched. So one of the main things that we did was we wanted to see what data was coming into the state. I think one of the things that we learned when we talked to other states is the structure is kind of a smaller DSNP team, but DSNP touches so many other areas. And sometimes you're just not aware of who is receiving data in regards to the DSNP population. So we wanted to connect with the Data Resource Center to determine what was coming into the state and then make an assessment as to how we were going to use that data. Again, with there being so many different pieces, if it was quality data or assessment information, like we started, I think, in the very beginning around quality, looking at how are we going to utilize the assessments and the data that was already coming in to gauge what the member experience was around the specific DSNP population. So as we reviewed that, then we were able to put some very specific things in place so that, you know, you get the data in, then you want to determine how am I going to use this data to inform how we move forward in the program and how we make improvements across the board for the DSNP members. So there was a lot of, and continues to be a lot of assessment around that specific quality piece. We've recently started looking at the encounter claims data so that we can drive cost, right? Where can we find those cost savings, those cost efficiencies, and determine where we can have fiscal savings for the state. So that's work that we are just now starting to get in the process of doing, knowing, you know, the number of claims that we have to review. That's a large amount of work for us to do. But as we determine how we will review the program from a day-to-day, week-to-week, month-to-month basis, we determined we needed a dashboard, right? So we had to determine what are the specific pieces of data that we need to review, you know, frequently to make quick decisions, informed decisions, and, you know, whatever came in, we could determine that this was accurate information, but we needed it at our fingertips. So now we're in the process of building a data dashboard specifically for the DSNP population that will inform us on our enrollment numbers, some quality quality percentages, assessment data, but just what we will utilize to feed into that as well. So working with the Data Resource Center, we got the template for the MMA files. So again, a lot of data going back and forth for Tennessee. That data goes back and forth on a daily basis. So we know we can always have accurate and up-to-date information to drive all of our decisions, because I've always come from the perspective of data should drive your decisions. So again, a lot of different perspectives when you look at data, but we had to sit and look at each piece one by one to determine how we would use that moving forward to inform our decisions for our members.
Thank you, Lolita. And we just know there's a lot of conversation around this, and there's even been, you know, requests for what tools are out there. So stay tuned. There's a lot of work to do in the area and work to support states on the data they receive and what they can do with the data meaningfully. I am going to now open this up and look into our Q&A chat. I just want to remind everyone that as we go through, since I didn't remind you at the beginning, the Q&A, you can please add additional questions as they come to mind. So the first one here is, and it is said, this is a question for all panelists. How are you working with or plan to work with disability groups as you design, oversee your programs? So I am going to just see who would like to answer this. I'm going to go to Lolita first.
Well, so I think for Tennessee, just a call we recently had with our state long-term care ombudsman. She really spoke to her connection with our Disability Rights Coalition. So I think it's extremely important for us to work with the disability agencies within the state because we're serving the same population, right? And so as we determine how we can utilize tools such as the SMAC and move forward initiatives, we really need individuals at the table that are serving the members that we serve on a day-to-day. So just looking at, again, the costs that are associated with members that have, more chronic health conditions, I think we really have to pay attention to what's being said. And a lot of times we're so busy driving the work, we don't always get the perspective of the individuals that are managing the work on the day-to-day basis, boots on the ground. So it's extremely important to us, like I said, just as we discussed, to ensure that we are providing the services and the benefits that the members actually need. We have to be in partnership with our disability coalitions.
Thank you, Lolita. And they are the ear to the ground and a source of information to really inform the program. So, Matt, I'm going to turn to you.
Yeah, that's a great question that really ties in with, Melanie's introduction, talking about how there's a couple of different populations that could actually fall under the DSNP space.
Matt, it's a little hard to hear you.
Can you hear me better now? Okay, good. So first of all, the DSNP program that we are standing up actually sits in a different bureau in state government than a lot of our other Medicaid managed care products. We're in the Bureau of Aging and Community Living Supports, which is really closely connected to the disability advocates. So we have standing Olmstead meetings. We have a standing ombudsman program that is really oriented towards disability rights. And I think that's sort of key with the connection. I'll also say that the Michigan Disability Rights Coalition, which is the local, Michigan-based coalition in that space, was very, very involved with the My Health Link program. Of course, that precedes our High D-SNP model and assisted us with outreach and designing marketing for the upcoming My Coordinated Health High D-SNP.
And Olivia, I know that you work closely with your aging disability partner agency. So just when I hand this over to you on, really connecting with the disability groups and receiving input.
Yeah, what we're doing in Maine is completely really a shared partnership with our Office of Aging and Disability Services, who have a number of standing relations with different groups within the state, not just the disability rights group. But I will say, as far as what Massachusetts has done, and we heard about this, the Medicare Academy and other avenues, it's really, I think, where I would like to see us go, where when Maine is looking to get to a place where we're more launching a duals effort, that we have a group established at the beginning of that process that will be giving us the real deal. From a consumer, from a member perspective, right now we have existing avenues, but not one, again, that's dedicated to specific reform that we're doing, because Maine isn't really at the point of designating an official plan or reform, or even officially planning for something like that. But regardless, I think that that is where we would like to be, is something close to what Massachusetts has done.
And just for everyone who's on, Massachusetts had their dual demonstration was called One Care, but the One Care Implementation Council, with representation from individuals, consumers, advocacy groups, and convened them on a regular basis and consulted them. And there's a lot more to that. And there's more information out there, but just wanted to reference that. I have a, you see, this is a shared savings question. Regarding shared savings and value-based arrangements, what are some of the largest cost items that states and plans should be thinking about? For example, rising personal care utilization and costs and tying independence interventions to outcomes. I'll let anyone raise their hand who would like to go first with that.
Well, I won't be, well, I'll speak about it from a different perspective, perhaps. I think the part of the challenge, and we know, is that what Medicaid invests in results in savings for Medicare, often can result in savings for Medicare, and we don't get any of those savings. So talking about behavioral health, you got to talk about long-term services and supports, of course, the things that you're mentioning. But what I think we have found too is that there's just other areas where the relationship between the primary and secondary payer do need to be explored further, and what your state policies and procedures are related to your third-party liability processes and your reimbursement logic for different things that even go to hospitals and DME and other products and services. So it's really vast. I think that you might be asking a different question for folks who have more of an integrated product. So I'll turn it over to them if they're looking at some of the performance measures that tie together the incentives around that.
Well, I think I'll say for Tennessee, that's something that we are currently exploring to determine how we can utilize some of the state incentives to drive that. But, as Matt spoke to, it's really incumbent upon us to ensure that we're reviewing that claims and encounter data to determine where those higher costs are coming from. And even as we work with our internal compliance divisions and our auditing departments to ensure that Medicaid is the payer of last resort, right? So sometimes you make those assumptions, but it may not always be true if you don't have those controls in place. But that's something that's, required and something that's very important to ensure that the state can have those cost savings and we can ensure that costs are being processed as they should. But it's not an easy process, but I think we are now starting to review again some of those incentives and bonus payment options to see how we can drive that in Tennessee.
And I'll just kind of cap it off, and hopefully people can hear me better now. I'll just cap it off by saying that, I'm a big believer in this sort of model. That's why I'm here. The jury is still out a little bit on the national data on how much savings has been or could be achieved in high D-SNP models. And I think it's certainly my belief and my hope that as these programs become more and more mature, that we will start to see some genuine savings. But those numbers that Melanie shared at the beginning of the presentation are very striking, that this is a very, very costly population, and it is difficult to realize savings in this space. A couple of places where we feel like we're quite confident that we were seeing savings in the duals demonstration that we believe will carry over. Our ER utilization was one of the key places where we noted definitively that the members we were serving had lower ER utilization, which is of course expensive. And then the even bigger area, of course, is any time that you can offer members home and community-based services that are keeping them out of nursing facilities, even though nursing facilities will be included in our program as well. And of course, they're very important to us in our state. But you can certainly find some savings there, which is something that these programs aim to achieve. So those are a couple of key places. We also do have an APM model built into our model of care, similar, of course, to our colleagues over there in Maine. And we have a quality withhold program as well. The quality measures that we have in our program aren't, of course, necessarily aimed towards cost savings, but certainly anytime you can improve quality of care across the population, you would expect to see lower ED utilization, lower utilization of some of those higher cost services.
think we have time for one more question because we've got questions in the pipeline here, which is great. So, and this may be more for Lolitha or Matt, which is for those moving towards the highly integrated and the fully integrated dual eligible special needs plans in 2026. How are you all preparing for exclusively aligned enrollment and crosswalking members from coordination only DSNPs over time? And I happen to know this may be a work in progress, but Lolitha, could I turn to you?
Sure. And I think somebody's been listening to our meetings. So yeah, this is definitely something that we are exploring in Tennessee. And I think because of some of the requirements in the final rule, some of these things are not fully fleshed out yet, right? We've been exploring the authority around crosswalking. But there's still some questions that we have. So we are presently conversing with CMS to see what opportunities there are for us to move individuals, if it's within the crosswalk option, if it's not. But with those requirements that are coming, minimizing the number of options and, reducing member confusion around all the different plan options. We don't know. I can't say right now that, this is a definitive answer, to say, hey, we're definitely going to do this. We're definitely going to do that. We know what authority we have. We know how the plans can currently crosswalk members within a health plan. And so, we've met with our plans. We've had those discussions. But as we move to wanting to ensure that as many members as possible are in the most integrated option, we have to seek guidance on that. And so we are in the process of determining, if you have two different healthcare plans and a member's in coordination only, what is the best option to move that member? Thus far, CMS has said that there are some very, strict requirements. Most people do not meet them, but we want to see if we have the ability to meet that and can handle those crosswalks within Tennessee, which would make it easier for us. But if not, then we will continue to do whatever we need to make sure that the members are aware of their options and the benefits around, moving into those more fully integrated products.
And I'm going to end with that on the questions, unless Matt, did you have something burning to say in this area?
Nothing burning. We're in a similar position to Tennessee, actually. So you can transpose that over to us as well for the most part, to tell you the truth.
Well, I want to thank everyone we received a ton of questions, and they were, we did not, have to use our back pocket questions. Some of these were tough, but I think really helpful to hear from 3 states, 2 with Medicaid managed care, 1 without Medicaid managed care, but also hear some themes around where we're seeing the increase in DSNP enrollment in DSNPs. And there are opportunities for states, no matter where you are, to really, as Olivia said, leverage the DSNPs and their networks and their ability to, support your program. And, Matt, with the capitated DSNP really, and having had the managed care operating in the state and the experience to really go out with a competitive procurement and clearly lay out what your goals are and how you're going to hold your plans accountable. And Lolitha really just moving forward with improving, enhancing a current program and making more people eligible, and really paying attention to quality and the data that's available and collecting meaningful data. And states really need help with, perhaps, I had someone state recently ask, what is a template? Or, is there anything out there to really help guide us? Just take the first steps for using our data. We have 1 minute left. And I just want to say thank you so much. Thank you to Melanie Bella for starting off the, setting the landscape and really setting the stage of why this work is so important. And everyone on this call and all the panelists, we share this real passion for making sure this population receives the care and supports that they need to live where they want to live and the life in the way they want to live it. So thank you all, and look forward to another gathering where we can share work across the states and bring everyone together. Thank you so much.